Hey everyone, thank you for coming. We are talking today about what you need on social needs. It's the top 10 articles on social emergency medicine. This is the QR code for the list of articles. I think it'll be available also afterwards if you guys would like to take a look at it. And then we also created a runner-up list, so I think those articles are also great.
Too many to choose from.
There's a lot to choose from, specifically 56. So this is sort of the methodology that we used. We searched PubMed and Google Scholar using those key terms plus emergency medicine, so all of these are EM papers. Last year, if any of you were at this lecture, we had excluded pediatric papers, but there were just really some great pediatric ones this year, and so we included those. We reviewed 56, we ranked 15, and then we finalized 10, which was difficult to do, which is why we have that runner-up list. We would be remiss not to mention these two articles that came out this year. One was, of course, the executive summary of the consensus conference last year. The other one was a scoping review of social EM literature from 1968 to July of 2020. So, if you're curious what's out there, that's the article to read. It is a pretty incredible article, not really in the scope of today's lecture, though, so that's why we didn't include it. So with that being said, I will go on to our first article, which is about human trafficking, and particularly about the feasibility of a screening tool for human trafficking. Human trafficking is a very vexing issue in the emergency department. It's a very small subset of the population, but we know that about 68% of people who are trafficked see a medical provider during the time period that they're being trafficked. So how do we recognize them? We know our gestalt is not great, and so it's very important to have some sort of an evidence-based tool that we can use on patients that we have a priori criteria to screen. And that's where this article came in. Interestingly, the objective of this article was to retrospectively assess a human trafficking tool that they created to see if it was feasible to do this in the emergency department. It was an 11-question tool. They screened a subpopulation based on chief complaint and provider suspicion, and the outcome of it was if you screened positive, you saw social work. But in actuality, what this paper describes is the making of the tool, the refining and the use of the tool, and then they talk about the feasibility and powering each question to see which questions are the most associated with being able to catch people who are being trafficked. Because there is no validated tool in the field of medicine at all for human trafficking, we had to look to our social work colleagues. They took this tool that was on the left and they simplified the questions. They made them all yes, no. And then they specifically made sure to include all of the questions that had to do with force, fraud, or coercion. They implemented this in their emergency department, did a pilot study, took feedback, and then they simplified the tool even more. Very important is to have a subpopulation when you're doing screening, because the prevalence of the people in the subpopulation that have the issue you're screening for really determines the success of your tool. And so the subpopulation that they decided on were based on these chief complaints. Red flag things like the person who is with the patient won't leave the room, and then provider suspicion. They excluded essentially anyone who couldn't answer questions in pediatric patients. They did a lot of math to power these questions. First, they looked at the entire screening tool and its association with positive screening for, or actually positive social work analysis of someone that was human trafficked. Then they looked at the predictive value of the tool as a whole, and then they looked at the predictive value of each question. They're really trying to narrow down this tool. These are numbers. But at the end of it, the question that was most associated, that had an odds ratio of more than 2, is does anyone make you have any kind of sex for work or money? Very direct question, yes or no. They screened 26,974 people. By the way, this is this part of this presentation is really where the title of the presentation starts. So all of that was work that they did prior to like writing up this paper. This is the feasibility part. So a lot of people who were screened, and out of those people, there were 197 positive. Out of the 197 positive, there were 42 that were likely human trafficked. That's like a huge number, very successful screening tool. So the take-home points, 68% of people are, of people who are human trafficked see medical providers. It's really a great opportunity for us to catch them when they come into the ED. This is a tool that will really help us get there. And additionally, even though there were so many screened and there were so many positives, they weren't all human trafficked, but a large number of them did have risk factors for abuse and exploitation, so the tool is very useful anyway. Implementation, which remember this was a feasibility study, is possible. It took a lot of education for the providers, a lot of support from the admin, a lot of operations support to do this. And lastly, I just wanted to mention that also this year there was a 5-question version of the same tool that came out called the RAFT tool. I'm sure you've all heard about it. It was a validation study. The reason that we chose not to use that was that we felt that the screening resulted in a much larger number of positive. And so we didn't really think that it was as efficient as this tool in narrowing things down. All right, next paper. Just this to advance. Yeah.
Cool, thanks. Hi, so this next paper examines the relationship between homelessness and ED wait time. So the background for this, we know that longer wait times lead to poorer patient care and sometimes increased morbidity and mortality. We also know from existing literature that there are racial disparities in wait times for ED visits. And this is the first paper to really parse out and examine homelessness as a risk factor for an increased wait time. So this was a retrospective cross-sectional study. They used data from the National Hospital Ambulatory Medical Care Survey, which is a national database used by the CDC for epidemiologic studies. And they collected data from 2014 to 2017, so over a 3-year period. And during this time, there was 432.7 million ED visits, which was kind of a whopping number. So this national data set is a sampling from that that's supposed to be representative. So in that data set, there was 62,657 visits that were represented. So researchers excluded 10,000 for missing data points that they needed. And then they examined several different variables looking at triage score, so acuity level, looking at patient factors and hospital factors to look at relationships with wait times. The primary outcome was wait time, which was designated as time of arrival to being seen by a physician, MD. They looked at different factors like I mentioned, age, sex, seasonality of the visits, whether or not there was a nursing bed coordinator in the hospital, whether it was a teaching hospital or a private practice hospital. And then the triage categories that they looked at was not the standard ESI. They looked at 5 triage categories. An immediate triage category was a patient that should be seen within 60 seconds of arrival, so like CPR in progress. The emergent category was the ideal time to physician time was between 1 and 15 minutes. Urgent was within an hour, so 15 minutes to an hour, and then so on with the lower acuity levels. So their main results, they found that when they did a univariate analysis, just looking at wait times, like mean ED wait time, and then whether a patient was domiciled or undomiciled, that univariate analysis showed that on average, homeless patients wait 14.6 minutes longer. When they made a multivariate analysis, this was also kind of borne out, and again, a very similar number. What I found striking about this article was when they looked at the higher acuity levels, so patients in the emergent and urgent categories, they found an even bigger disparity. Homeless patients were waiting over an hour to be seen by a physician, even in these emergent and urgent categories. So the take-home points are like when you control for things like race and urbanicity of a hospital, whether it's a teaching hospital, undomiciled patients are waiting longer to be seen, and that this is more pronounced at the higher acuity levels, which is pretty concerning. So, researchers speculated why this might be happening. They wondered about implicit bias. They wondered about provider factors or patient factors and how those might be playing in, but further research is definitely necessary.
All right, next article. So this article is called Talking About Firearm Injury and Gun Violence, Words Matter. So this one we liked for a variety of reasons, but it's very practical, and I think something that we can all sort of take some information away and incorporate into our day-to-day practice. So I'd encourage you to take a closer look at it. So the context for this is that there's been, so much political debate between gun rights and gun control that a lot of the terms that we use around firearms have become very politically charged. And so there's also, a good body of evidence that supports physicians having conversations about firearm safety with our patients. And so with that in mind, this was sort of a group of experts with a ton of experience working with firearms, sort of trying to create a body of both kind of, practices, strategies for discussing safety around firearms, and also specific terminology to have culturally respectful conversation promoting language with patients. And so they broke it into 3 different categories, sort of firearms and firearm safety, suicide by firearm, and then community violence involving firearms. The first category, so language around firearm ownership and storage. I included some of the examples of like specific terminology that they recommend. I included it for each category, but there's additional terms in the paper, so take a look at those. But so here in this category, they discuss the diversity of gun ownership and people's motivations for owning guns, and sort of highlight the importance of not making assumptions about people's motivations, their access, their attitudes, or their risks of injury just based on their demographics or their political affiliations. So as an example, you see up there, instead of using terms like restriction, surrender, or confiscation, they recommended using transfer, relinquishment, or temporary removal to avoid being provocative and differentiate between enforced versus voluntary action. So the next category, language around suicide and firearms. So here they discuss some specific recommendations around safety measures and how to have these conversations with patients and their families. So they talk about storage of firearms, transfer of possession, and then they get into some of the laws that can restrict this practice. And then the last category is language around community violence and firearms. So here they talk about some of the risk factors related to being a victim of community violence and the importance of using trauma-informed care in having these one-on-one conversations with patients. So we want to try to avoid criminalizing people who are affected by violence, suggesting blame, highlighting past history with violence or criminalization, and really trying to sort of prioritize the needs of the patient as opposed to any sort of like interrogation or information gathering. So take-homes here, yes, we should be having these discussions with our patients to try to promote firearm safety, and there's a way to go about it that is going to sort of, maximize the likelihood that you're able to have a trustful, engaging conversation with a patient. So take a look at these specific strategies and specific language that they recommend.
Thank you. All right. Our next article is about health equity. It is important. How do we measure it and how do we monitor it? So this is a systematic review that used routinely collected administrative data. So we're already using this data. It's like recidivism to the emergency department, preventable visits, things like this. So since we already collect this data, it's not any increased burden, but they looked at these studies that collected this data and included like retrospective cohorts, cross-sectional studies, small ecological studies. The one thing is this was an adults-only study, and it was only high-income countries. The socioeconomic determinants of health that they used were level of education, financial resources, social and material living conditions. They interestingly didn't use race or ethnicity, and I think like that's important for the United States because that's a very, it is a factor by which when we stratify, we do see a lot of disparities. So the objective of this review was actually to try to come up with a way that we can create a set of valuable and reliable indicators that can be used to identify and analyze healthcare equity in all kinds of settings. What they did was feed these terms, health service accessibility, health equity, healthcare disparities, plus administrative terms, plus emergency care or emergencies into like the usual suspects for databases, and then they also put them into Google Scholar. They got 226. Out of those, they reviewed abstracts. They narrowed it down to 79, which they reviewed the full article. And then they had 29, and then they tested those studies for bias. And in the end, there were 28 studies that were indicated. Also, one very interesting thing is that they recognize that patients see the healthcare system along a continuum. So they broke down the quality indicators into categories that fall in that continuum. So group 1 assessed access to high quality outpatient care. So for example, if you have people coming again and again to the emergency department for preventable visits, it may be an indicator that there aren't enough federal qualified healthcare clinics in the community to see them. Group 2 was the actual quality of emergency care. Group 3 was the inpatient care or care after the emergency department, and that was measured by things like post-operative complications. So they stratified all of these by those socioeconomic determinants of health, and this is each of the articles that you guys can read later. But bottom line is that all of the identified socioeconomic determinants of health were associated with inequalities in access to and use of emergency care. And I think that's pretty important. From that, they derived this conceptual model saying like, hey, we can use these categories and we can use them anywhere because we already collect this data. The take home is using this sort of combination of indicators for health equity, I think, is very important because health equity is a really complex subject and measuring it is very, very difficult. We can use this routinely collected data so that we don't have to stray outside of what we're already doing. And this has a potential to show equity concerns in very targeted areas and will help us target our interventions to those areas. Is it you? It's all right.
We've all read these articles so many times, it's hard to remember who's doing what. So this next one is from JAMA Psychiatry, so not a usual journal to publish emergency medicine studies, but it examines trends in ED visits, both before and then during the initial COVID pandemic. So looking at overdose visits, mental health visits, including suicide attempts, and then violence outcomes, including child abuse and neglect and interpersonal violence. So this was a cross-sectional study. They used data from a national database, the CDC's National Syndromic Surveillance Program. Data in this large database captures about 70% of ED visits in the United States. So it includes information from 48 different states and DC, encompassing 3,500 EDs, so a pretty big data set. And researchers looked at weekly ED visit case counts in 2019 and then in 2020. And they also looked at rates of visits because we know those changed dramatically after stay-at-home orders were in place. So what they found was that, oh, and sorry, I'm going to go back one slide. They studied the changes in ED visits associated with those listed outcomes that I mentioned. So that dashed line down the center of the graph shows when kind of national stay-at-home orders were suggested and put in place in varying parts of our country. And so we saw a dip in all ED visits when that happened, including for all of our specific disease processes that we're studying here, and then an uptick. And so when they broke it down for each of these outcomes that we're studying on the left side of this table, and they looked at the second kind of 3/4 of the year, basically after March of 2019 and after March of 2020, so weeks 12 to 41 of these 2 years. Those are represented on the right side of this table. And what we can see is that there's a significant increase in almost all of these categories. So mental health conditions went up, visits for that went up, suicide attempts went up, all drug overdoses and especially opioid overdoses went up, and that trend has continued since 2020, as we know. Interpersonal violence, intimate partner violence was the only outcome that didn't go up in this registry, and so it's not clear if that's a real thing or if that was just a weird statistical analysis, but then child abuse and neglect did increase. So the take-home points from this is that overall ED visits for all of these outcomes did increase during the pandemic, and that the overdoses had a pretty big increase in 2020, especially opioids. So researchers speculated why. Was it just increased care-seeking behavior, or were this a really increased burden of disease? But looking at completed suicide deaths as well as overdose deaths, which also increased, it suggests that there's actually an increased true burden of disease for all of these processes. And so it suggests that we should integrate this knowledge into our pandemic response kind of going forward.
All right, next paper. So staying on the topic of addiction, so we have a qualitative study of ED patients who survived an opioid overdose, perspectives on treatment and unmet needs. So the context for this paper, obviously we all know the burden of opioids. We presented a paper last year that showed that 5% of patients, there's 5% 1-year mortality for patients who survive a non-fatal opioid overdose who are seen in the emergency department. We also know that at this point there's a pretty strong foundation of evidence that gives us a variety of tools that we can use to treat opioid use disorder in the emergency department. So this paper is sort of getting at the question of how do we motivate patients, what motivates patients to accept care and enhance their linkage to care after they leave the ED. So they explored patient perspectives on substance use treatment, their perceived needs, and then contextual factors that shape their decisions around engagement with treatment during that acute post-overdose phase. So they did a brief quantitative survey, and then they did semi-structured interviews with 24 adult ED patients in a single urban academic ED, and then they identified themes across 4 levels of the modified social ecologic model, so individual, interpersonal, organizational, and structural. Patients were 33 years old on average, 83% white, 12% black, 2/3 male, 83% met criteria for opioid use disorder, and they had an average of 3.25 self-reported lifetime opioid overdoses. So the themes here, so the first, there was wide variability in patient perception about their own ability to control drug use. Some people felt really confident. Some people felt like they had absolutely no control over their drug use. Most participants had some prior experience with treatment that sort of informed their current decisions about whether to engage in treatment. Overall, patients didn't have a lot of faith in medications to limit their drug use once they left the emergency department. People mentioned relationships with friends and family as a major factor for consideration of treatment, and that was both in the positive and the negative. They mentioned provider communication skills as something that can exacerbate especially feelings of shame, guilt, anger, and then some highlighted the importance of empathetic listening on behalf of the provider. Stigma was a significant barrier to accessing care and feeling comfortable with care in the emergency department, and also mentioned as a barrier to engaging with treatment upon discharge. Everyone felt that the ED should play a role in providing care, mentioning specifically harm reduction and efforts to address unmet social needs. People mentioned challenges of requirements for entry into substance use treatment, so specifically finances, insurance, things like not being sick enough. And then people highlighted support for unmet needs like employment and mental health as important factors in their decisions around engagement with treatment. So take-homes, I think this just sort of highlights the need for a patient-centered approach when we're trying to offer treatment to our patients with opioid use disorder. Obviously, the resources we have are only as useful as the ones that patients actually accept and actively engage with. And I think it just sort of highlights the need for a kind of broader understanding of what it means to treat someone with opioid use disorder and really having an empathetic approach to patients. So I have the next one as well, another substance use paper. So this is about an implementation of oral and extended release naltrexone for the treatment of ED patients with moderate to severe alcohol use disorder, feasibility and initial outcomes. So the context for this, we know that naltrexone is an effective treatment for alcohol use disorder, and obviously alcohol is a tremendous public health problem. Doesn't matter what ED you work in, we see tons of patients that struggle with alcohol. But use of naltrexone in the ED has not really been described in the literature previously. So this team implemented a protocol that combined substance use navigation with either oral naltrexone or extended release IM naltrexone for patients with moderate to severe alcohol use disorder. And then they looked at their engagement with outpatient treatment within 30 days. So they were adult patients discharged from the ED, and then the 30-day follow-up, as I mentioned. So they had 345 patients who had moderate to severe alcohol use disorder based on their diagnostic codes. 59 of them were eligible for treatment and accepted the treatment. 41 of those were oral, and 18 were extended release injection. And it's not clear sort of how they decided who got which treatment approach. Average age was 45, 37% Latinx, 31% Black, 27% white. And the primary outcomes, so at 30 days, 28% who received the extended release and about 10% who received the oral naltrexone attended follow-up outpatient treatment. So a lot more people got the oral, but a smaller percentage of those patients followed up with outpatient treatment. So take-homes for this, I think we need to be realistic about the ED as a touch point for patients with alcohol use disorder. It's a huge number of patients, and sort of think more actively about how we can help them. So this study showed that it's feasible to start patients on naltrexone in the ED and work on engaging them in outpatient addiction treatment. And I think there's certainly more research needed, a prospective study with hopefully larger numbers. But I think of this as a little bit analogous to some of the landmark buprenorphine papers in terms of, hey, we can kind of expand our idea of what the emergency department is and potentially start patients on treatment in the ED that can be really impactful in the long term.
Yeah, I thought that was a really interesting paper too. Like, one caveat is naltrexone IM injections are more than $2,000 per.
Yeah, they're expensive.
So like in our ED, we're allowed 5 from the pharmacy per month. And that might have been the difference between the oral and the IM as well. So, but if you have it in your ED, worth a try.
Yeah, I asked last week and they said no at Harborview. We should check at Alaska Native.
Yeah. And it stops cravings that's the idea behind it. So it's unlike Suboxone where there's actually like a receptor thing. Naltrexone is just like, I don't want to drink anymore.
Yeah.
maybe.
Okay, totally different topic. The Vote ER campaign published a paper about their work. And so we included this next paper, even though it's quite small, and it's a descriptive piece of research about basically the work of a nonprofit, nonpartisan organization called Vote ER. The goal of this organization was to encourage civic engagement, and they use the emergency department as a place to enroll voters to register to vote. So in 2020, they recruited medical students from each of these states that are in this graph with the color on them, or this graphic image. So they included medical students from 80 different medical schools to serve as captains for teams to recruit voters in various emergency departments. So they had 128 students. They recruited 15,692 adults to vote in this arena. And they looked at a post-survey showing the medical students' reasons for participating in this organization. And they showed that their motivation was mainly to improve and address kind of social and racial inequities in healthcare. So we included this study just because it's a very novel use of the emergency department for really not healthcare at all, but for civic engagement in our democracy in an election year. So this might be trend-setting in light of the emergency department for preventative care, especially with respect to vaccination and other kind of public health measures, just as a way to reach people.
Speaking of reaching people, so this study, I just want to mention kind of globally, there are a lot of papers that came out this year about the use of the emergency department, both since the Affordable Care Act. I think there's 7-8 years of data now, and there's been a lot of analyses on it, and then various subpopulations within that. My personal feeling is COVID ended, and now there's a floodgate of everything people were trying to publish before COVID, because we were sort of obsessed with the COVID-related research. It was very hard to choose one that we felt was important. So please do take a look. There's a lot of interesting data, and a lot of it varies from state to state, depending on how the Affordable Care Act was actually implemented in that state. And also the political leanings of the state, surprise, surprise. So this article is changes in healthcare usage among undocumented immigrants in the years 2014 to 2018. Sorry, I just couldn't remember exactly what years they were. So the study, so basically they wanted to look at if there was a difference in the difference between primary care visits and a difference in the difference between ED visits before and after an inflection point, which is shown on the graph. The inflection point was actually the announcement of the candidacy of Trump, and the reason that it was around the announcement and not the actual campaigning was because that was sort of the start of this anti-immigrant rhetoric. Largely in the media, I think that generally in the population, people started talking about it a lot more. So that's the inflection point. The population that they looked at, this was a Johns Hopkins study, and Johns Hopkins healthcare system has two programs. One is called the TAP program, the Access Partnership. It's a fee waiver program for Medicaid ineligible adults and children. And then there's another one which is called the Sliding Scale program, and that is for the uninsurable that can't afford to pay a little bit. None of this group comes and says we're undocumented and we want to be part of these two programs. It's just that these two programs have 90% of the undocumented patients that come to the Johns Hopkins healthcare system. And they did a lot of adjustments for no-shows and various things that you would want to make sure that were accounted for. These are all of the adjustments that they did. So they actually calculated the difference of ED admission rates versus inpatient discharges. They re-estimated everything for children. They took out hospitalizations. They redid the calculation specifically for Hispanic and Latino kids. They redid it for the 18 to 69-year-old group to eliminate those who became Medicare eligible during the time of the study. And then they just played around with the distribution, and they were like, what if this was a Gaussian distribution instead of a binomial distribution? I don't know. It would really change things, I guess. So the controls were the years of birth, the self-reported sex, the Elixhauer Comorbidity Index. The scores were drawn from the first year of data for each individual. So these were the things that reached significance. So adults and children, both categories, there was a decrease in their primary care visits. That was the primary outcome. So there was a hesitancy to come to primary care, essentially. In the emergency department, the one that reached significant was that the number of children coming into the emergency department increased by 2.3, which is quite a bit. Adults also increased, but it didn't reach significance. The inpatient discharges, though, for adults decreased quite a bit. And so the idea is that, if you compare that to the emergency department visits for adults versus the people who were actually discharged, there was actually a decrease. And the children, it didn't reach significance. So the take-home point of all of this, actually, is that there was a huge chilling effect, which I think we all knew. We all saw it in different ways. But this actually shows it. It shows it in the Johns Hopkins system, but there were similar papers that were done in Texas and even done in sanctuary cities. So like LA, San Francisco, places where you would think that the anti-immigrant rhetoric didn't matter as much, it still did matter. And for the general population health, this is very, very important because it's incredibly necessary for children to get their immunizations. There was a huge measles outbreak after this happened. And now that, of course, we have COVID and we're dependent on herd immunity, it's really important to encourage everybody to come and get care, primary care or ED care, however you want to do it. And then essentially for those of us in the emergency department, it's really necessary for people who have chronic diseases like hypertension and diabetes to go to their primary care and continue to be managed so that they don't result in emergencies. Keep in mind the state of hypervigilance that many of these undocumented immigrants were in already, because suffering from PTSD, coming from the Central Americas, having to try to cross our border, and then coming here and seeing ICE break into people's houses. This was a really one of the most concerning things that happened, I think, in the field of public health. And I think that this is a really important study for that reason. And then this is our last paper. Exciting.
Yes.
Here you go.
Well, as promised, we have a pediatric-specific paper this year. So in 2021, there was a series of papers looking at racial disparities in both adult and pediatric care. This article was published in a special issue of Academic Emergency Medicine in the fall of 2021 that comprised of articles all related to health equity. So I highly recommend taking a look at that issue. So we chose this article specifically because it looks at racial disparities in a clinical setting where there were clinical guidelines in place that were put in place specifically to help provide equitable care and kind of mitigate some of these issues that are known. So the setting for this study on racial disparities in the care of patients with pediatric gastroenteritis was a New England academic pediatric emergency department. They used QI data, so it was a retrospective study. And the QI data was comprised of patients that visited between the years of 2011 and 2018. They excluded patients who were over 18 or under 6 months of age, and those with ESIs of 1 and 2. And that's because they figured those kids would be more likely to receive IV fluids, and that was one of the outcomes they were studying. So it was kind of more moderately or less sick kids. The average age of the child in this study was 3 to 4 years old. And so researchers examined the relationship between increase or between oral rehydration, ondansetron use, IV fluid use, because oral rehydration was being promoted over IV fluid use. And they looked at ED length of stay and whether or not these kids were admitted. And then they looked at the relationship between the children's self-identified race that was happening at triage. So there were 30,849 visits during this period for acute gastroenteritis and dehydration. The different racial categories that patients self-identified to are listed at the top there, and you can see the numbers of children that were in each group. So there was non-Hispanic white, non-Hispanic black, Hispanic or non-Hispanic other were the groups. And then the outcomes that they looked at were ondansetron use, yes or no, IV fluids, yes or no, with the alternative being oral rehydration. They looked at mean length of stay in minutes, and then whether or not the children were admitted. They used a 72-hour revisit rate as kind of a proxy to figure out whether they were under-treating, like whether these kids were coming back after receiving these treatments. So this is their main results in graphic form. The dashed line represents the non-Hispanic white children. So compared to the reference line, the non-Hispanic white children, the graph shows that all groups were actually less likely to receive IV fluids and less likely to be admitted to the hospital. The length of stay was also shorter for other groups, but the revisit rate was the same, so no difference. And so that suggests over-treatment of the non-Hispanic white children rather than under-treatment of all the other children. And so the discussion kind of meanders around why this might be the case. It references other studies looking at over-treatment of white children compared to other racial groups, such as head CT in minor head injury, looking at antibiotic use in viral syndromes with kids. And they speculate that it might be due to implicit bias or other factors that they couldn't figure out in this particular study. But we thought this was important to highlight because it shows that even in the presence of a clinical guideline that's helping to really standardized care across the spectrum, you can still see racial disparities, and it's still important to restudy those even after implementation of clinical guidelines. So that is our last paper of our top 10 in 2021, and we thank you for being in this very freezing room, and we thank you for your time. And as Ayesha mentioned, we have that QR code that links to our list of all of our articles, as well as our honorable mentions that we thought were great reading. So,
Also, we have 20 minutes, so if someone has a question, please feel free to ask. Yeah. I should have put it on the last slide too. Sorry. Questions? No?
Nobody have a seizure? I'm going really fast.
Yeah. Nobody wants to delve into the methods of any of these. No. Yes, go ahead.
I will just mention, because we also discussed a similar paper that's reviewed at the and there's a bronchitis paper in addition.
Yeah.
It's a theme.
Yes, it's a theme.
The thing I worry about this is generally I feel like the treatment effect of any disease is relatively small. And usually when we're finding racial disparities, my suspicion is that we're usually measuring one of probably two things. Either we're measuring outcomes of structural racism that affect treatment and outcome differences that we're measuring in before the patient arrives. Or in this case, I think, this is kind of coming to the fore, we're actually measuring what I'll just call white privilege or the privilege of, non-Hispanic white patients. The problem, I think, is that there's a dominant narrative, I think, in the press and even that it probably affects, emergency medicine, literature, what's out there, that the disparities are actually maltreatment.
Right. Yeah.
And
Rather than
again,
over-treatment.
Not that there's not maltreatment. I believe that there's maltreatment. I think racism and even the fairly explicit biases are prevalent among people who try emergency care. But I think it's important that we start, at least from an editorial standpoint, under fleshing out that I think that people are actually generally getting care, and the disparities that we're seeing are that people are essentially, and this is very hard to qualify
So I just want to repeat your comment because I think there were some people in the back who were saying that they couldn't hear. Allow me to try to summarize. I'm sorry. So I think what you're saying is that the way that these papers show this, it looks as though there's maltreatment of non-white children, whether it's like in bronchiolitis or gastroenteritis, or perhaps even in the studies that have adults, and that's the dominant narrative in the media. But oftentimes it's overtreatment. Like this paper actually showed overtreatment of white kids, and what is happening is that we are providing largely evidence-based care, but that patients feel or they're coming with an expectation that they might be maltreated. Do you want to comment on that, or?
I think from an editorial standpoint for these journals, right, like when I read that title, I expected to read a paper where the children were being maltreated who were not white. And instead, if they had titled it, like over-treatment and over-testing of, non-Hispanic white children occurs in gastroenteritis, even in the setting of a clinical pathway. And why did this happen? You can't go back retrospectively and interview the parents. Like, were they coming in with expectations for IV fluid and admission for their kid with diarrhea? And so I think it's really complicated, and I think there's, with pediatric patients, Gesundheit, there is this whole parent factor with expectations. I mean, this is an academic pediatric emergency department in New England, and so I'm sure parents came in with expectations, and so in the absence of a prospective way to study that, I think it's hard, but I think even just retitling and kind of representing the information, because it was in this journal with the bronchiolitis paper and then the appendicitis paper showing worse outcomes for children with appendicitis if they were black, and so I think it's a mixed kind of picture of what's happening out there. Yeah.
And I mean, if I may say, I think the more important thing to realize here is that there's disparity. Like whether it is somebody being overtreated or whether it's people just getting children of color get evidence-based care, white kids get too much care, or they get overtreated. The point is there's disparity, and there shouldn't be disparity for whatever reason we are doing it, whether it's because, my underlying feeling about this is that there's differences in power structures within society, right? So there's probably physicians that are concerned about people in neighborhoods that have privilege and power complaining to the hospital, donors in the hospital complaining. So they may overtreat kids that are white. And I think those power structures really need to be addressed. The hospital is just one endpoint of where we see that disparity. Definitely this is a much larger structural issue which goes back to redlining and segregation and basically our entire country is built upon these power dynamics and structures. So I think it's a larger conversation, but what I do like about these papers and the reason that we presented them is regardless of which way the treatment is going, there is a disparity. And I know there is an expectation of treatment, but that arises from a mistrust of the healthcare system that I think is deserved, and this need for and feeling for people that come from this historical mistrust to advocate for themselves.
And I don't mean to discount
Yeah,
this.
absolutely.
This
Yeah.
is obviously a very important justice issue.
Yeah,
Even
yeah.
white patients are even in some of these studies where non-Hispanic white patients are getting excessive or non-evidence-based care, that illustrates all the issues you're talking about. Structural parts. I think another thing though is that a lot of these papers where the top, where the headline is essentially racial disparities, also kind of, I think, often imply or even sometimes they're very explicit about in the introduction or discussion of okay, we found these differences and it's probably implicit bias, and then which kind of suggests that maybe the remedy is implicit bias training for the providers, or the provider level problem, and then maybe there's some truth in all that, but I think then that kind of elides addressing a lot of the structural factors and how we should actually be doing that.
Yeah.
Obviously, I think we're over here and we need to get here. So I'm trying to be
Yeah, I agree.
Yeah,
Yeah.
definitely.
I mean, I think, yeah, implicit bias training, it's interesting because like you take a test and it tells you that you're biased implicitly, and then it's like, okay, so what do I do about that? I don't, and the best you can do is bring more awareness to it, but I think like more practically, just allowing yourself to spend more time with patients that come from historically disadvantaged communities to explain to them like what evidence-based treatment is, why you are giving them the treatment you're giving them. I try to always like say like, hey, if this doesn't work, these are your next steps. Like I am here. I usually tell them the next shift I'm working, like, and it's usually like, I'm also working tomorrow at this time. Come in and I will personally see you again if you don't feel better or if things aren't getting better. Allowing for a little, like that's, there's this idea of horizontal equity where like everyone who comes in gets the same health care, but then there's also vertical equity where you give care according to need. And I think that little bit of extra time often makes the difference. And I think headlines like this will, I mean, they'll always exist, especially in the media, because people are trying for that shock value. But the pendulum like is always going to swing one way or the other before it like gets to like where we need to be, I think. Sorry, I feel like I'm getting like soapboxy. So, does anybody else have any comments or anything to say? Thank you guys so much for coming to our talk. This was like, final hour of a very long conference in a very cold room. We were really expecting to fill all these seats, so thank you guys for coming. We appreciate it.